Spinal anesthesia is commonly performed for surgical procedures below the umbilicus. Neuraxial anesthesia refers to the administration of local anesthetic medications into the spinal and epidural space. The term intrathecal or subarachnoid space refers to the spinal fluid space lined by the dura containing the cerebrospinal fluid. Spinal anesthesia is conducted by injecting a local anesthetic solution into the cerebrospinal fluid. The benefits of regional anesthesia, as well as the absolute and relative contraindications to performing neuraxial anesthesia, are discussed in Chapter 16 of the Ottawa Anesthesia Primer. Tuffier's line refers to an imaginary line that is drawn across the superior aspects of the iliac crest. It generally intersects the body of the fourth lumbar vertebrae. The interspaces immediately above and below Tuffier's line correspond to the L3-4 and L4-5 interspaces respectively. The termination of the spinal cord occurs at the L1-2 interspace. Spinal anesthesia is administered below this space to avoid direct spinal cord injury from the spinal needle. Prior to performing spinal anesthesia, an intravenous is established and standard monitors including pulse oximetry and a non-invasive blood pressure monitor are applied. The patient can be positioned either sitting or on their side. The patient is instructed to curl and round their lower back to open the spaces between the spinous processes. One of the complications of spinal anesthesia is the development of a dural puncture headache. The incidence of a post-dural puncture headache ranges from 0.2 to 14% and increases in patients less than 60 years, with larger bore spinal needles, and with multiple attempts at spinal anesthesia. This can result in a debilitating post-dural puncture headache that can persist for a couple of weeks. The incidence of a post-dural puncture headache can be reduced using a specially designed spinal needle with a pencil point needle tip that divides rather than cuts the dural fibers. Common sized needles used for spinal anesthesia range from a very fine 27 gauge needle to a relatively larger 22 gauge needle. In contrast, an epidural needle, which is typically a 17 gauge size, is a much larger needle diameter compared to a spinal needle. A local anesthetic solution is prepared for spinal anesthesia. 10 to 15 milligrams of bupivacaine in a concentration of 0.75 or 0.5% is commonly chosen as a local anesthetic solution used to perform spinal anesthesia. A small amount of opioid, such as fentanyl or preservative-free morphine, may be added to the bupivacaine solution. The administration of 100 to 200 micrograms of spinal morphine can provide prolonged postoperative analgesia for up to 18 to 24 hours. Common side effects of spinal morphine include pruritus and the risk of delayed respiratory depression. The administration of spinal morphine requires that the patient be monitored in hospital for 24 hours. A strict aseptic technique is maintained during the procedure. The skin is cleansed with a chlorhexidine alcohol preparation and a sterile drape is placed on the patient's back. Local anesthesia, using 1 to 2% plain lidocaine through a fine gauge needle, is used to minimize patient discomfort during the procedure. Small amounts of intravenous sedative and analgesic medications, such as midazolam and fentanyl, may also be administered to minimize patient discomfort and anxiety. A short introducing needle can be used to increase the stability of a fine gauge spinal needle as it is directed towards the intrathecal space. The needle is directed toward the intrathecal space in a 10-degree cephalad direction using either a midline or paramedian approach. The depth to the intrathecal space in adults is typically 5 to 6 centimeters, but may be deeper in larger patients. As the needle tip passes through the dura, the clinician may sense a subtle pop. The stylet is removed and the spinal needle is examined for return of spinal fluid. Once free-flowing spinal fluid is obtained, the local anesthetic syringe is attached. Entry into the CSF fluid space is confirmed with intermittent aspiration, and the local anesthetic medication is administered. The spinal needle is then removed and the patient is positioned for the surgical procedure. Administration of the local anesthetic medication into the CSF space will result in a rapid block of the motor, sensory, and autonomic nerves. The spread of the spinal block is determined by the dose of local anesthetic administered, its sphericity, as well as the position of the patient. Spinal anesthesia blocks the motor and sensory nerves, resulting in anesthesia and skeletal muscle paralysis below the umbilicus. Blockade of the autonomic nerves results in vasodilation of the venous and arterial vascular systems that can result in a significant decrease in blood pressure. If the spinal block spreads higher, it may block the cardiac acceleratory fibers at T1 to T4, resulting in significant bradycardia. With a high block, the patient may also lose sensation of their chest wall and experience a sensation of having difficulty breathing. The patient's blood pressure, heart rate, and oxygen saturation should be monitored frequently. Administration of vasopressors such as ephedrine, atropine, and phenylephrine, as well as the administration of intravenous fluids, may be required to maintain normal hemodynamics. Other complications related to spinal anesthesia are discussed in Chapter 16 of the Ottawa Anesthesia Primer.
Is it still there now? Or?
There is the master.